Hello, my name is Leslee Shaw. I was the principal investigator for the imaging core laboratories for the ischemia trial and was heavily involved in both COURAGE and BERRY 2D trials. All of these trials were stable coronary disease trials. I'd like to share with you my perspective on the ischemia trial findings, what led up to the trial design issues, especially as it pertains to stress imaging. Here you see the 2012 Stable Ischemic Heart Disease Clinical Practice Guidelines from the American Heart Association, American College of Cardiology. At the heart of decision-making in the patient with known coronary disease is stress imaging-based evidence of inducible ischemia, both the extent and severity, for intensification of guideline-directed medical therapy, as well as decision-making around coronary revascularization, with an aim towards improvement of symptoms. A lot of this evidence prior to ischemia, COURAGE, and BERRY 2D was based upon observational findings, which suggested that revascularization was associated with an improvement in outcome when patients had moderate to severe ischemia, or in the case of SPECT imaging, when the ischemic myocardium was greater than 10% of the burden of ischemia. This was recently validated with PET imaging from data from Krishna Patel, as well as from Tim Bateman, also supporting the fact that a threshold of 10% or more ischemic myocardium was associated with an improvement in outcome for patients that were treated with prompt or early revascularization. Unfortunately, those observational findings were not actually replicated or validated in stable ischemic heart disease trials such as COURAGE and BERRY 2D. Both stable coronary disease trials, the only difference in BERRY 2D was that that was a patient population with type 2 diabetes. One of the challenges with both of these trials is that the eligibility criteria really were only offered minimal ischemia. And often the ischemia was very, very small and without prognostic significance. In the case of COURAGE, anatomic eligibility not requiring ischemia was also allowed and included somewhere around 12% of patients. And now what we do see is in contradiction is that the FAME trial, which many of you are well aware of, fractional flow reserve guided PCI, so lesion-specific ischemia. We previously talked about myocardial ischemia, but as we move to more specific lesion-specific ischemia in the FAME trial, we see that FFR ischemia, or a fractional flow reserve less than 0.8, reduced the primary endpoint, death, myocardial infarction, or urgent revascularization, by 68%. And those results actually remained lower for patients who had FFR-guided PCI versus medical therapy through 5 years of follow-up. This was the basis for the ischemia trial. And what we see here is the design of the ischemia trial with stable patients with moderate to severe ischemia as determined by sites were referred for a blinded CT angiogram. The purpose of the blinded CT angiogram was to identify patients with non-obstructive disease, who obviously shouldn't be treated similarly to patients with obstructive disease, at least based upon current evidence, as well as to identify patients with a significant left main stenosis who should be treated more intensively, for whom revascularization is associated with improvement in outcome. And those patients who met both of these eligibility criteria were randomized to a strategy, an invasive strategy, which considered optimal medical therapy plus cath and optimal revascularization, or a conservative strategy with optimal medical therapy, where catheterization was reserved in the setting of patients that failed medical therapy. So here's the hypothesis. In stable patients with at least moderate to severe ischemia on a stress test, is there a benefit to adding cardiac catheterization and, if feasible, revascularization to improve optimal medical therapy? Now here is the stress test criteria. SPECT or PET, 10% of the myocardium. We actually tried to match echo and CMR criteria based upon event rates or prognosis. So here's what we came up with. 3 or more segments with severe hypokinesis or akinesis on echo had a similar rate of cardiac death or myocardial infarction. to those SPECT or PET patients with moderate to severe ischemia. You can see that similarly with the CMR, 32 segments versus the traditional 17 or 20 segments with SPECT or PET imaging. So we get a little bit greater amount of myocardium that's ischemic in terms of our threshold criteria. Some partway into the trial, we added exercise ECG to broaden the eligibility criteria and allow for folks from all around the world, and particularly India and China, who don't use as much stress imaging, to enroll patients. We required patients who were enrolled with exercise ECG to have a history of typical angina or exertional angina on the exercise test. They had to have a relatively normal rest electrocardiogram, at least no resting SC segment depression or any kind of confounding measurements such as a left bundle branch block or LVH. They had to have exhibited exertional horizontal or downsloping SC segment depression at least 1.5 millimeters in 2 leads, or marked SC segment depression in 2 millimeters, or SC elevation in a non-Q wave lead. These ECG criteria had to be met at a reduced workload, and in order to enhance the accuracy of this, enhance the risk in this population, we required a greater severity of stenosis on CTA. As you can see here, it's an important consideration between the modality. Now here you see the baseline paper, which was published in JAMA Cardiology in 2019. A lot of diabetics in this cohort. Basically patients with preserved left ventricular function. The vast majority of patients had a history of angina, although not as many had angina over the past several months. These are important considerations. The CoreLab interpretation of ischemia is on this slide. You can see about half the patients were enrolled from following nuclear imaging, 21% with echo, a small number with MR, and about a quarter with exercise ECG. About half the patients had severe ischemia, a third of the patients had moderate ischemia, and then around 13% had insufficient ischemia. You can see kind of the criteria and how many patients, about 600 patients met criteria having insufficient ischemia that were randomized in this trial. A lot of patients with a lot of disease. Many patients had left anterior descending defined disease, as well as about 2/3 of the patients had multi-vessel coronary disease. Patients did well in terms of risk factor management throughout the trial. Here you can see the data from baseline to the last visit. There were no between group differences for those patients who were randomized to invasive versus conservative strategies. And you can see, if you take home messages, if you look at the far right column, you can see high-level prevention optimization, which the trial is defined as an LDL less than 70, plus a patient being on statin therapy, a systolic blood pressure under 140, patients on aspirin or some other alternative antiplatelet or anticoagulant therapies, and the patient not smoking. Patients did well in terms of improving their adherence to secondary prevention therapies. Here's some data on the cumulative invasive procedural use. You can see that for cardiac catheterization, as you would expect, the invasive arm actually had very prompt and early, they early underwent cardiac catheterization. Did not happen so much with revascularization. There were about 400 patients that did not have revascularization in that invasive arm. About half of those patients were deemed at the time of invasive coronary angiography to have insignificant coronary disease, so that's about 200 patients. 26% of these had extensive coronary disease that was deemed unsuitable to revascularization. And of those patients treated with revascularization, about 3/4 went to PCI, about a quarter to coronary bypass surgery, with the vast majority of being successful procedures. There were a group of patients, particularly in the conservative arm, that had an early event or OMT failure, which is an important consideration in those treated conservatively and a take-home message for the trial. And you can see that within 6 weeks, only about half the patients underwent revascularization, which suggested that decision-making around these patients was more protracted, perhaps reflecting the stability of these patient populations. Here's the primary endpoint, the conservative and the invasive arm. You can see there was no difference in outcome at 3.3 years of follow-up in this large sample. Here's the difference in the event rates at 4 years. At around 6 months of follow-up, there was a 1.9% difference between the invasive arm versus the conservative arm in terms of the primary endpoint, supporting a more near-term clinical worsening in invasively treated folks, largely periprocedural myocardial infarctions. And then we see a late benefit in terms of a reduction in events within those invasively treated patients at 4 years, largely due to a reduction in the incidence of spontaneous myocardial infarction, which is an early hazard, but potentially a late benefit. Certainly in making it intriguing that hopefully these investigators will continue to follow these patients so we can see if that late-term benefit actually widens over additional follow-up. So here we have some questions. Is early harm related to the completeness of revascularization? That analysis is still ongoing. Is the late benefit sustainable over a longer term of follow-up? Now, in all of the pre-specified subgroups, there was no heterogeneity of treatment effect. What that means is if I look at either the whether or not the CoreLab determined ischemia eligibility or the extent or the severity of ischemia, there was no difference in outcomes, so there was no subgroups for whom the overall results didn't apply. And you can see here that if you look at none to mild, moderate, or severe, there was a trend towards a favorability versus in the invasive arm, but certainly that difference was not statistically significant, and that p-value at 0.80 was not even remotely significant. Now, of course, you have to realize that severe ischemia also included patients with an exercise ECG, wall motion plus perfusion. It'll be important for us to see some differences between these types of modalities to see if there's any additional insight we might garner into any type of optimal medical treatments in these patient populations. Here you can see these results depicted using cumulative incident curves. And again, replicating the findings from the prior. There's actually no 4-year event rate interaction between those with severe, moderate ischemia or those without eligibility. Now, one of the factors that we see is that the Seattle Angina Questionnaire results really give us a different twist on the overall ischemia trial findings. And what you can see is those patients that were treated invasively had a prompt improvement in their anginal symptoms, and it was durable over the course of 4 years of follow-up. And of course, this is consistent with prior coronary disease trials, particularly COURAGE, that showed the exact same findings. Now, there was some interesting findings that you can see here. These are posterior probability curves, and I apologize for that, but I really like the way this is presented. So what you see on this, with the same Seattle Angina Questionnaire, you see in the typical patient here with daily to weekly angina, both at 3 months, 12 months, and then at 36 months. And all of that curve, that probability density curve, is over to the right, and this supports that you have an improvement in angina in those patients with daily to weekly angina if they were treated with an invasive strategy. And you can actually see, if you compare this to those patients with monthly angina, you can actually see that same favorability towards invasive care. However, in the patient with no angina at the time of enrollment, you can see that that favorability to invasive care is eliminated. This is important because in many cases, patients who are asymptomatic with coronary disease and a lot of ischemia previously were treated in the same pattern. And many patients were treated in the same pattern and treated with revascularization. And this actually supports, as you would expect, but it's nice to see it in the analysis, that absence of angina is not going to yield a favorability in terms of reduction in angina. important kind of caveats to that patient who's asymptomatic with a lot of ischemia. Of course, again, this is consistent with prior trials. So in summary, we see that an initial invasive strategy does not reduce risk over 3 years. The invasive strategy does improve angina. And so of course, this is then becomes a lifestyle and a shared decision-making between the patient and you as clinicians as to whether or not they would like a reduction in angina. Of course, these same results in terms of improving angina don't apply to the patient who is asymptomatic. Certainly, I think the use of CTA to detect left main disease and to exclude non-obstructive disease is an important part of the trial design. One would reasonably ask about the role of atherosclerotic plaque, and that is an ongoing analysis. So now what do we do? Certainly, I think you have clear evidence the patient with frequent angina, prompt re-angiography, and accordingly, revascularization as appropriate. We'd like to see more data about ischemia-guided revascularization, and certainly there's ongoing analysis about medical management from the conservative arm of the trial that will help stress imagers from all around the world. But let's take a little bit deeper dive. Some additional thoughts. Invasive therapy for those with frequent angina, but are there additional anatomic subgroups that may also fit into that category? Proximal LAD disease, patients with more extensive disease, patients with more severe lesions, and how does ischemia mediate that symptom benefit? In other words, a patient has a large anterior ischemic defect, proximal LAD stenosis. Does that patient also benefit from invasive therapy? And I think on the conservative arm, certainly the conservative arm is preferred, but what about ischemia subgroups that had early events? We need to learn from those groups. And or folks that had early OMT failure, who are they? And there subgroups with more severe ischemia who may benefit from invasive therapies. These are still ongoing analysis, which I think can really help us in understanding the value of the ischemia trial. Well, thank you so much for listening to this, and I hope we get to see each other again in person someday soon, and I hope you all are staying well. I'm going to sign off from New York City and hope to see you all soon.